Hello, dear doctors. I would like to extend a warm welcome to each one of you. This is Dr. Salman, and today we are going to explore a fascinating case that I believe will stimulate insightful discussion and provide valuable takeaways for all of us. We'll look into the case of a 52-year-old man, a smoker with hypertension, who presented to the emergency department with sudden onset severe chest pain. As we navigate through this case, we will touch on several key aspects from the initial presentation, diagnostic process, and management strategies to the patient's journey and follow-up care. In doing so, we aim to enhance our understanding of clinical reasoning, evidence-based management, and the importance of preventive health education. The goal of today's discussion is not merely to highlight the medical specifics of this case, but to emphasize the critical role that rapid diagnosis, patient education, and lifestyle modifications plays in managing cardiovascular health, particularly among high-risk patients. Remember, our purpose here is to learn from each other, so I strongly encourage you to share your insights, experiences, and queries as we move along. Once again, I appreciate your presence and look forward to an engaging and enlightening session. Let's begin. Patient is a 52-year-old man with a history of smoking and hypertension. He arrived at the emergency room experiencing sudden and severe chest pain. He described it as crushing pain radiating to his left arm and jaw, along with associated shortness of breath and profuse sweating. Upon taking a detailed history, we learned that he has had episodes of exertional chest discomfort in the past, which he neglected. He also mentioned waking up shortness of breath during the night on a few occasions. He has a history of poorly controlled hypertension and a 30-year history of examination. He appeared anxious and distressed. His blood pressure was elevated and his heart rate was fast. An immediate ECG showed ST segment elevations in the anterior leads, suggestive of an anterior wall myocardial infarction. This was later confirmed with elevated cardiac enzymes. Considering his age, risk factors, and the classic presentation, the primary diagnosis of ST-Elevation Myocardial Infarction was made. It's important to remember the variety of conditions that can present with chest pain and why. In this case, other diagnoses such as aortic dissection, pulmonary embolism, and pericarditis considered but ruled out. During the diagnosis, our management focused on immediate reperfusion. Aspirin was administered and he was taken for an urgent percutaneous coronary intervention, PCI, where a stent was successfully placed in his occluded coronary artery. Post-procedure, he was started on dual antiplatelet therapy, beta blockers, statins, and of course ACE inhibitors. He was enrolled in a cardiac rehabilitation program and advised on necessary lifestyle changes. Reflecting on this case highlights the importance of public education about the warning signs of heart disease. Our patient has been experiencing symptoms of angina and nocturnal dyspnea for some time, but failed to seek medical attention until the acute event. So, our patient's management was in line with current AHA, that is American Heart Association, and ACC, that is American College of Cardiology guidelines, emphasizing the need for immediate reperfusion, dual antiplatelet therapy, and comprehensive secondary prevention measures following a myocardial infarction. In this case, we have learned the vital importance of rapid diagnosis and management of acute myocardial infarction and how crucial patient education is for early symptoms recognition. In future practice, we should continuously focus on patient education regarding heart disease, especially in those with risk factors. This is your online medical educator, Dr. Salman, signing off.